Well, good afternoon, everyone. Thanks for joining us. This is Symposium 6, Preliminary Findings of the Mental Health Block Grant, 10% Set Aside, National Evaluation of Coordinated Specialty Care. And I'll be your facilitator, but my main responsibility is really to introduce our chair, Abram Rosenblatt. Dr. Rosenblatt is from Westat, and I am going to turn it over to him now. Thank you.
Thanks. Wow, applause before we start talking. That's a good sign. So it's after lunch. Thank you all for coming on a whatever kind of day it is out there. I thought I'd harken back just to get started for a second on the Valley of Death that we heard about this morning from in the first session. This presentation comes to you directly from the Valley of Death. That's where we live, between implementation and research. And it's okay because I grew up in Arizona and went to grad school in Arizona, and Preeti also went to grad school in Arizona. So as long as it's a dry heat, we're fine in the Valley of Death. It's a little bit better than it is outside right now. So it's a great privilege to be able to be here and talk with you all today. I'll introduce some of our panelists as we get to that part of the slides, so you know where they fit in. And we've got 3 talks and a discussant for you for this afternoon. First off, I want to thank our funders. We were funded by the Center for Mental Health Services Administration, the National Institute of Mental Health. Thank you, National Institute of Mental Health. And the Office of the Assistant Secretary for Planning and Evaluation, and they funded this work. We're the company that's been contracted to do this work, Westat. It's a research company up in Rockville. Come on by and visit if you're in the neighborhood. We'd love to hear from you all. Not all of you at once, at a time, let us know. And also the NRI and NASBID, who are our collaborators. So this is our evaluation team. I'm the principal investigator of the project. We have some senior investigators, Lisa Dixon and Howard Goldman. Tara is standing in for Lisa today because Lisa had some family issues that kept her from attending, and she's going to be our discussant. And we're delighted to have you. Our project manager is Preeti George, my fellow Arizonan, and she's run the project. And we also have a research methods group that includes the folks listed here. Many folks who have worked in this area of early psychosis intervention. Gary Bond is leading our Fidelity team, and Valerie Noel is going to represent our Fidelity measures. So we have 3 presentations. There we go. Nothing like hearing yourself live. That's really good. I'm going to deepen my voice now a little bit. I don't want to see the video. I think we'll wait till that gets wrapped up over there. Good. Okay. So here's the objectives of the overall evaluation. Now, we're going to identify and describe coordinated specialty care program services being offered nationally. This is a national evaluation, covers a lot of programs. We assess the program fidelity to the NIMH coordinated specialty care model. We're going to look at local environmental and contextual factors related to how the programs are implemented, and we also explore the outcomes of program participants. So this is a national evaluation. It's largely descriptive by design, although we're going to be looking at the relationship between fidelity and outcomes and some of the process indicators and outcomes. We have 36 study sites for a 3-year evaluation. We just completed the first year of data collection, so you guys are going to be the first people in the world, aside from us and our collaborators in the federal government, to see some of this data. So consider yourselves lucky or something like that. And we selected sites based across the different regions. We wanted to vary them in terms of program model types. They varied in terms of the services implementation status. You'll see some of that. Variation on the TA that was received at the start of the program, and urban rural. So there's a lot of natural variation across these 36 sites. This was our site selection process. You can see we went through a structured process of identifying them. There were 216 sites, and we narrowed those down to a possible list of 56 to get to our 36 sites. They had to receive mental health block grant funding from their state. So I believe most of you know, but I'll just say quickly, SAMHSA provides mental health block grants to all the states, and the block grants are used by states for a variety of mental health services. Legislation passed at some, I forget when, but they passed legislation, you probably know, Susan, to set aside some of those dollars to be used for early psychosis programs, beginning with 5%, and then it became 10%, hence our catchphrase, the mental health block grant, 10% set aside evaluation. That's really fun to say, I know. And we also wanted to be sure that they were implementing the elements of coordinated specialty care in the model, and that the site was serving clients and was willing to work with our study team. So we're very appreciative that these sites were willing to work for us. They received very little, virtually nothing really, to participate, except the knowledge that they're contributing to the greater good, and so that's really terrific. So we have 4 study components. You're going to hear from a couple of them today. We have the data collection activity, the site survey. That's 248 sites across the country. So we'll be giving you some results from the site survey. And for the sites that were participating in the national evaluation, we have 3 data collection elements: an outcomes assessment, a fidelity assessment, and a process assessment. We will not have the outcome assessment data for you today because we just finished the first round of data collection, so you don't have outcomes usually until some time passes to get more outcome data. So we'll stay tuned for that one. You're going to hear something about the fidelity assessment today, and really mostly how it was designed and what the fidelity assessment looks like. We're quite proud of our work in that area. And then you'll see some results from our process assessment, which was a qualitative set of interviews around implementation of coordinated specialty care services in the sites. This is a timeline, basically where we're at. We just finished our Time 1 data collection. It's a mixed methods design. As we said, we have an overview of the programs nationally. We have an outcome analysis, fidelity assessment, and process assessment. This is what the site survey does, so you're going to see some data from this, and it tries to look at the better understanding of the CSE programs nationally and get some information from them around participation, treatment services, duration of care, what outcome measures they're using. There's a client outcome assessment. These are the measures we're using on the outcome assessment. Again, you won't see data on these, but you might be interested in them. We picked these to be as brief and also as good a quality as possible because sites are giving us this data, and also to be measures that were typically used in sites and in coordinated specialty care programs. So we have the modified Colorado Symptom Index, the brief psychiatric rating scale if they had it, the MyREC-GAF symptom scale if they had it, and then some quality of life functioning measures, the global functioning, social role functioning scales, the layman quality of life scale, the global scale. I love this scale. Have you guys seen it? It goes delighted, terrible. Applies to almost all circumstances. So at the end of this, you can say whether the presentation was delighted or terrible, or you were delighted or terrible. And then you can think about how you're feeling now. How are you guys now? Delighted? Terrible? Somewhere between? There you go. And then, if available, the MyREC-GAF, which is a social functioning, occupational functioning scale from that. The fidelity assessment, which you'll also be seeing some more further description of, it's conducted remotely by a trained assessor, and I don't think I'll go into that here because you're going to cover that for us, Valerie. The process assessment are semi-structured in-person interviews with the program administrators at the sites, the team leaders, clients in the program, and the state behavioral authority representative. We did that by phone. Tara participated in one of those, and she can tell you how much fun that was. In fact, I did your interview. So, and so that's an overview of that. Now I have the most difficult task I'm going to have in this presentation, which is to get to the next slide. And if I do that, I am delighted. Okay. So this is a look at the SAMHSA-funded first programs for first episode psychosis across the U.S., those that are using mental health block grant funding. And our goal here was, again, to get, I already described this, but to give us a better understanding of these programs nationally and the services they offer. We did an online instrument, 28 questions. There were 2 conditions of eligibility. They had to currently be serving clients, and they have to receive mental health 10% set-aside funding funds, so pretty basic. We sent out 250 invites. We had the survey available for a period from February to June of this year. And by the end, 215 sites completed the survey and 6 were ineligible. So our final response rate was 88%. We are really happy to get an 88% response rate on a site survey going out to sites where they're completing this. And again, they're not receiving any particular dispensation for doing this other than to participate. So we're really quite pleased with that. And it probably says a lot about how dedicated these sites are to these programs. These are the locations of the responding programs, so you can find your favorite location and see where it is. But you can see they were across the country, fairly widely dispersed. Here's who responded to the survey. We had mostly leaders and administrators, team leads, clinical directors and supervisors or other. So we had a range of different respondents, but by and large they were program leaders or team leads. So this is an interesting slide. It's also colorful, which is a plus. And you can see that this is the year that the programs began serving people with first episode psychosis against the time they began serving people with mental illness. You can see that most of these programs, I've got a nice little arrow here. Yeah. Most of these programs actually began opening and serving people with mental illness way back in 1980 or 82, so they've been around a long time. But what's significant here is the growth in first episode psychosis programs. And that growth, if you like reading these, does tend to coincide with the funding of the guidance provided by states, by NIMH and SAMHSA, the set-aside for first episode psychosis, and the coverage of the first episode psychosis intervention services, and then the set-aside, again, that was done later in 2015. So you can see that huge amount of growth right around here, 2014, 2015, and when these sites began. So this is obviously one case where federal intervention and federal training and all those kinds of things led to a real explosion in services for individuals with first episode psychosis, experiencing first episode psychosis. This one is, which of the following models did you receive technical assistance or training from? And you can receive training on more than one model. So if those of you, and we have a research audience, you're probably already doing the math in your head and going, why is it more than 100%? And that's generally the case for many of these items. They can receive multiple training. Most receive training from On Track, which is the program out of New York, Navigate or ESA out of Portland, and then we had models scattered around with other first peer or some that said, one or two that said they didn't have any training. So On Track, Navigate, and ESA were the most popular. The number of active clients varied quite a bit. Some programs were very small, from 0 to 10. Some were quite large. A majority, 51 clients. So there's a tremendous amount of variability in the size of these programs nationally. The programs also vary as to how full they are, how they are running to capacity. Some are obviously 6% over 100%. That doesn't sound like a very fun program to have to work in, probably very, very busy. But many are running in the 50 to 99%, and some are still have a lot of room. So one of the things that we do ask in our process interview that you may hear some more about later is how sites recruit folks into their services. The average duration of care varies. Some are more than 3 years and some are less, but generally they're in the 1 to 2 to 2 to 3 year range. And our values didn't come out for some strange reason when we made these widescreen, but it's about, what do you guys think? You're all researchers, 45, 55, I can't remember, something like that. As far as referral sources go, they come from a lot of different places, psychiatric inpatient facilities, outpatient clinics. You can go ahead and take a look down the list. I don't need to read them all to you. But you can see a wide range from corrections to inpatient facilities, so a lot of different referral sources. Most were funded from state block grant early intervention set-aside funds. That's the blue. I do know that. And the other ones were funded by other means. And again, we have this, I don't know why we had that problem. It's weird. It was fine when we looked at it before, but whatever. And did they receive support from other sources other than mental health block grant funds? There's about a third that did. Treatment services and supports offered, again, vary. These are typical CSC type services. They include family education and support, all the way down to neuropsych assessment down at the bottom and occupational therapy. But by and large, if you take a look at 71% or above, you can see substance use services, primary care coordination, peer support. A wide range of different services are being provided across the country in these programs, ones that are consistent with coordinated specialty care especially. Do they have a team lead? That means yes, the blue. So yes, most programs do have a team lead. Do they have enrollment criteria? It's a good thing I looked at these beforehand. The blue is yes, most do. And if so, as far as enrollment criteria, what is the time period that they've been serving these youth? And you can see most have criteria for about 2 years for duration of first onset. So the time period generally runs 2 years to 3 years, but mostly 2 to 1.5 years, and some about 1 year. Do they have enrollment criteria about whether the person was prescribed antipsychotic medication? I can tell you that the purple is yes, so most do. What kind of training was provided to staff? There was a lot of different kinds of training: rationale for early intervention, client-family engagement, shared decision-making, components for coordinated specialty care. So a wide range of different kinds of training was provided to the staff. As far as how they're staffed, a lot of variation here. 3 or fewer FTE. Oh, it's a common response, so 45%. So that's a very small number, obviously, for the program. And then some programs had 7 or more FTEs. So there's quite a bit of variation, though most actually were fairly small in terms of the number of FTE, full-time equivalent positions dedicated to the program. As far as family engagement, you can see a number of strategies, including education. Family members invited to participate, psychoeducational services, but the main takeaway here is all of these numbers are well above 80%. So a lot of different strategies, a lot of things that are being used to engage families. And then these are some of the outcome measures. I think most of these would look familiar to you all, but again, a lot of outcome measures being used, a lot around psychiatric hospitalization, employment, school participation, justice involvement, homelessness. Those kinds of things. Relatively fewer physical health, as you might expect, but only 3% are not collecting outcome measures. That's only like 1 or 2 respondents. Is there a designated person at the site who looks at client outcome data? I believe the blue is yes, so yes. If yes, are they tracked systematically at the caseload level? Most are tracking them at the caseload level and comparing over time. Not as many compared to benchmarks, because benchmarks are hard to come by. So a lot of outcome data collection going on in these sites, and a lot of monitoring of data, of outcomes. Do they use a Fidelity tool? The blue is yes, but the purple is no. And so a lot of sites are not using an actual coordinated specialty care specific Fidelity tool like the one that we're going to cover in the rest of our presentation. Most accept a wide range of insurance. You can see 93% accept Medicaid, 62 Medicare, 76 private. So many of these programs really rely on Medicaid, which we also actually did encounter in our process interviews. So some takeaways. There was a large increase in programs providing first episode services coinciding with set-aside funding and CMS coverage. Most programs are implementing Navigate, OnTrack, or ESA models, and they do receive TA directly from those models. The active clients, as you saw, do vary by capacity. Many programs do rely entirely on mental health block grant funding. So that's a very important funding source, obviously, for these programs. If they're unable to find other funding, they'll have a challenging time to continuing. Programs do provide a wide range of services. They use a whole host of different referral sources. About half the programs use the Fidelity tool, so not a huge number, about half. And almost all of them accept Medicaid, and about 3/4 accept private insurance. So they do use other funding mechanisms, but they really rely on the mental health block grant dollars. So that's a look across 200 some odd sites across the country. You can see that's not all of our data. We have a lot of descriptive information about these programs that I think we haven't had before. So we're going to be very interested as we dig a bit more into all of this and also compare it to the sites that we actually then collected data from. So, Preeti.
Great. Okay.
I can
You have to
manage.
pick number 3.
That's right.
There you go.
Okay, great. Okay, well, good afternoon, everybody. Thank you so much for joining us. We're so glad that you showed interest in our session, and we're delighted to share information about our study as we learn about it. So you just heard from Abram sort of a broad picture of CSE programs that were sort of reviewed and surveyed nationally. What I'm going to do in this presentation is focus more in-depthly on the 36 sites that are included in our Mental Health Block Grant 10% study. So in general, we are interested in understanding a little bit about the local context in which these coordinated specialty care programs are delivering services. And in particular for our 36 sites, we want to know about whether the local context in which they're operating has sort of an influence on the way that treatment services are being delivered and how program staff perceive that local context to affect their work. So in this particular presentation, I'm going to be talking about the process assessment, which is what Abram just mentioned in his overview, and that is the qualitative component of this evaluation that sort of looks at the local context of the different programs and asks them to sort of discuss the implementation issues that they might be experiencing in delivering CSC. And in particular, for this presentation, what we'd like to do is talk about the local accommodations to the CSE model that sites reported that they are using in response to that local context. So first what I'll do is I'll just provide you some brief background information about the 36 sites that are in our program, and then just deliver just sort of a little summary of the process assessment data collection, and then we'll actually talk about the accommodations that sites reported that they're using to implement CSE. Okay, so as Abram mentioned, there are 36 sites. All of them are using mental health block grant set-aside funds for some aspect of their coordinated specialty care programs. And the sites that are in our study, they reported using 7 different CSE program models. All of them implement coordinated specialty care, but they have different types of CSE models that are in use. For example, first, we have On Track, ESA, Navigate. Some of them use hybrids of those models. And so this is a map of the 36 sites that are in our study. You'll see we have some geographic spread here. We have sites that are represented in 9 of the 10 DHHS regions of the United States. And just a few background slides about the sort of local context of these programs. This is the catchment area size. So for the programs that indicated that they had a catchment area, using U.S. Census data, we looked to see sort of what the catchment area size was of those local programs. And we have some programs that are offering services to those areas for less than 175,000. I think the lowest number of the catchment area size is for a community serving 50,000. And then we have sites that are serving catchment areas of 3 million or more. So we have a wide range. Similarly, we have different levels of catchment areas served by these sites. The majority, almost half of the programs that are in our study indicated that they serve a single county. Others served multi-county areas, and we have some that are serving combinations of cities and states and local jurisdictions as well. The number of active clients varies too. We have some programs that are offering services to a very small number of clients, less than 10, others that are serving 55 or more. So we have a broad range, most of them serving the numbers between 10 and 40 clients. So just more in depth about the process assessment. So like I mentioned, we're interested in understanding not just the fidelity and the outcome data, clinical outcome data, but we want to learn more about the implementation and the local context in which these programs are operating. So our process assessment was designed to examine that. And the way that we use the process assessment is to do site visits. So we visited all 36 sites and did interviews with various staff at each of the sites. So we spoke with program directors, administrators, as well as the clinical team. We spoke with some clients that were recipients of the services or recent graduates of the program. And we also spoke with state mental health directors for the states in which our programs are located. So in general, overall, after this first year of data collection, we spoke with 210 clinical CSE staff. We interviewed 35 administrators, 22 state behavioral health authority representatives, and 58 clients. So that was kind of a fun experience to visit all these different sites. We got to travel as far as Puerto Rico, Oregon, all over. You got to go there. Puerto Rico. It was a fascinating experience, and Tara was one of our sites we visited too. So it was a great experience to actually see the context in which these programs are being implemented and sort of see on the ground what clients and what staff are seeing as they provide services. So we audio recorded all the interviews and then had them professionally transcribed. And we used the data from those transcriptions with a qualitative software programming analytical tool. And so in our particular interview, what we are focusing on here are sort of the local contextual factors that sites sort of have to face, and how do they sort of provide accommodations to the CSE model to address those local factors. So we asked sites, and in particular for this presentation, we'll talk about interviews we did with the CSE clinical staff as well as the administrators. So we asked them about what are some of the ways that you've modified your services to address local contextual factors, including things like the language of your clients, the demographic characteristics of your clients, sociodemographic factors of the community, and other sort of factors. And so in order to do our analysis, what we first did was sort of looked at the responses to those questions and identified any other places within our interviews where they talked about accommodations to the model. And then we extracted the key responses that sort of described the accommodation that they were discussing. And then we did some coding of those data, and we looked at the type of accommodation and the general driving factor for that accommodation as reported by the sites. So these are all self-report data. So using the coding, what we essentially want to know is we want to know what type of accommodations did sites reportedly make to their CSE models to accommodate local factors, and why were those accommodations being made? So let's just talk about the types of accommodations. There were basically 5 different categories that we found. Most prominently, aspects of treatment provision was the area in which most of the accommodations to the model were made. Locations or the modality of work was also represented. The cultural awareness and language of the populations they're serving, staffing issues, as well as some other accommodation factors, which we'll talk about in just a moment. So let's talk about that first one, aspects of treatment provision. So that was by far the one that was most prominently named by clinical staff, and it basically fell into 4 different areas. The first one, being the most prominent, was to add an approach or therapy that wasn't necessarily part of the model or increase some use or aspect of the model. So for example, add dialectical behavior therapy to your clinical treatment plan, or add the use of peers in providing services, or increase case management or psychoeducation, depending on the needs of the client. Other ways that treatment provision was addressed was to, several sites said that they use individual psychoeducation with families rather than providing psychoeducation through multifamily groups. And that may not necessarily be a specific accommodation to the CSE model, but sites perceived that to be an accommodation that they were making. Another was to change the language or the order of the modules to try to help clients understand the content, and also to take away an approach or a therapy. So for example, don't always use cognitive behaviorally oriented therapies. The next type of accommodation was the location of treatment. And for the majority of the individuals who responded, they indicated that visiting clients in their homes and in the community was something that they practiced. And it wasn't just their therapist, but it was all members of their team to try to help provide transportation, meet community members in the community, and also to use technology to work with clients. So for example, one of the respondents indicated that they're more creative in terms of using telepsychiatry to address clients that may not be able to come to their locations. We also heard people talk about cultural awareness and language supports. So much of the discussion was here related to attention to language, providing translation, bilingual therapists, other types of things to sort of accommodate people with other language, and also to address cultural factors such as religion or gender that could be sort of something relevant to their treatment. Staffing or staff patterns was another accommodation that were named. So for example, some of the examples people talked about were to have staff fill multiple roles. So given the context of their team, they had some folks doing both case management and being the recovery coach, or doing supported education duties as well as case management. Other areas that people mentioned that they did in terms of accommodations to the model were related to policy, training, or outreach. And some of these are sort of related to having flexibility in terms of when individuals would receive services, having additional trainings if they needed additional trainings for their staff, and also to be attending to outreach and making sure that they provide outreach to populations that were historically underrepresented. So now that we talked about the types of accommodations, here are some information about the driving factors that individuals sort of responded about why they do these accommodations. And they fell into basically three categories. We have characteristics of the population served, factors related to the agency or team, and then characteristics of the community. So in terms of characteristics of the population served, individuals reported that they made these accommodations in order to address cultural and language issues of their clients, to accommodate personal preferences. So for example, if they were family members that didn't like sharing in groups, that they would do individualized psychoeducation, to try to address the clinical presentation of the individuals they were seeing, so to add trauma-focused treatments or social skills training, for example, to address those issues. The economic backgrounds of their clients. So if clients couldn't afford transportation, if they had challenges in terms of missing work in order to be with the therapist, they would be very flexible in terms of accommodating those needs. And also trying to incorporate or at least acknowledge religious beliefs about causes, symptoms, and treatment, and sort of incorporating that in their treatment. The factors related to the agency or program, a lot of these sort of examples that people discussed as sort of driving forces for these accommodations was sort of to address, based on clinicians' experience, what did they think would be most helpful in sort of facilitating engagement with their clients. So some of the things they talked about was, well, we have peers who work on our team, and that shared experience is very helpful in terms of helping with engagement and participation in the program. So those were some of the factors they talked about there. And then also characteristics of the community. So there were some sites that indicated that there was limited bus service, little or no low-cost housing, and so they tried to make accommodations in the types of services they provided to address those needs. Similarly, if there was a very large catchment area, families might be dispersed across large areas. And so one of the challenges, for example, that rural areas, some sites indicated that they faced having a very large population, a large geographic area, but the population base on which to sort of have clients was smaller. So there was a lot of geographical navigation that they had to do to get to clients that they needed to see. So what are some key takeaways from all of these qualitative data? Some of the key sort of accommodations to the model kind of just reflect good clinical practice. Things like translation or bilingual therapists or interpretation, those are all things that I think all good clinicians would try to do to try to help facilitate clinical practice. Some accommodations seem to reflect an extra effort of staff to be sensitive to the economic and other barriers that clients faced. And other accommodations seem to provide sort of an accumulated experience of staff and what they thought would be helpful in keeping clients engaged. So those are some of the key takeaways we learned from our first wave of qualitative data. We're going to go out into the field next year and go and do site visits again. And so we hope to have more information to contextualize some of the quantitative work that we're going to be collecting as well. So that's it.
So our next presentation is on Fidelity with Valerie Noel. I want to just really quickly, though, before I forget, acknowledge that while we're up here speaking, our colleagues at Westat and elsewhere did a lot of work on this presentation. Particularly Jennifer O'Brien did some of the work on the site survey that you saw. And Tamara Daly did a lot of the coding and work with us on the qualitative interviews. And you can imagine there's a lot more data in those qualitative interviews. And also I want to thank Lisa Dixon and Howard Goldman, who gave us a lot of feedback and help in framing the presentation. Just wanted to be sure we acknowledge some of our colleagues. And our next one's on Fidelity. So, Valerie.
Thank you, Abram. I'm 3.
You are?
4. Okay, great.
And then F5.
Okay, great. And then I have this. All right, thank you so much. So with the 36 sites spanning across the U.S., we were faced with the challenge as to how we would conduct a fidelity review at each site with the limited people power that we have, which I think was me. So, so the method we chose to overcome this challenge was to use a remote fidelity review method, which I'll describe, along with I'll provide you some preliminary inter-rater reliability statistics and discuss some of the benefits and limitations that we experienced and identified throughout the process. So firstly, our first step was to identify the Fidelity Scale. So around the world, there are many endeavors aimed at providing services for those experiencing a first episode psychosis. And so researchers have developed fidelity scales in order to assess the level of delivery of these services. And so the development of scales can be informed by research evidence. It can be informed by the practices of a program model, such as what we have here is the OPUS, which is from Denmark, and EPIC, which is a fidelity scale made in Australia. They can also be informed, in addition, by expert consensus, which we have the EDEN, which is from the UK, and ESA, which is from here. We'll just skip that. So as Abram and Preeti had described, the programs that we were evaluating were diverse. They used different models, such as the Navigate model, OnTrack, ESA. Some programs used elements from a few of those. Some programs didn't use any of any model and kind of made their own model. So we weren't able to use a fidelity scale that was based on a specific model. So what we ended up choosing in the end was the first episode Psychosis Fidelity Scale. And so this is a 31-item evidence-based scale. It's rated on a 5-point scale, and it was developed through knowledge synthesis. So it's research from empirical studies, meta-analysis, systematic reviews, and also incorporating expert opinion to developing it. And this scale works because it wasn't developed based on a model, and so it will work across all models, another reason why we've chosen it. It has shown good inter-rater reliability, and there is evidence also for face validity. Go back to this. And so, in addition, these 31 items also have the greatest content overlap over the other, I believe, 5 fidelity scales that I've shown you. So this fidelity scale almost encompasses all of the content areas that the other 5 fidelity scales currently examine. And so the programs that we were evaluating follow the principles and components of the coordinated specialty care model. And so the fidelity scale that we chose needed to assess these principles, which the FEPS-FS does. These principles of the coordinated specialty care model being that it's a team-based approach, levels of certain characteristics in team leadership, there has to be case management, provide supported employment and supported education services, psychotherapy, also family psychoeducation, and pharmacotherapy in primary care. So now to the evaluation. So in this first year, we made several modifications. The first modification was modifying the procedure, because this scale, the FEPS-FS, was used for fidelity reviews at on-site visits. We needed to come up with a procedure as to how to do this remotely. We also modified the interviews. These interviews typically done in a site visit. We had to modify them for doing them remotely. And we also removed 3 items from the Fidelity Scale in the past year. And we also modified some of the anchors on the Fidelity items. I'll give an example of an item later on. So to conduct the remote fidelity assessment, we developed a process for data gathering, and in that we required a certain level of training. So we held 2 training sessions. One training session is for the site team leader, and this is an opportunity for us to tell them what to expect in a remote fidelity review. And then we needed to hold a second training session, and this would be for the person that we would identify at the site who would be responsible for collecting client-level data. Because we are so dependent on the sites for providing us with quality-level data, we felt providing them with a manual wouldn't be sufficient. And so we had one-on-one trainings with each team leader and each health record reviewer at each site. Then the data gathering methods for conducting a remote fidelity review, where we conducted telephone interviews, we reviewed program documents that were sent to us from the sites, and we reviewed client-level data. So the first is the telephone interviews, where we interviewed 4 staff members. That would be the team leader, the therapist, the supported employment or supported education specialist, and the prescriber. And this isn't saying that these are the most important team members or the key roles on the team. Rather, we wanted to keep the burden as low as possible when doing the remote fidelity review. And we felt that interviewing these 4 staff members would give us the spread of information that would be required to complete the review. In some cases, some roles were split, and so we would have to interview a few more staff members, or some staff. So there have been times when I would interview someone and they wouldn't be able to speak to certain questions, and so I'd request to speak with another staff member to get information on those certain areas. So next is the documentation. We requested programs to send this to us electronically, and we also asked them to send us this information in advance. It allowed us to prepare for the interviews. And I should say that this also would be used to corroborate information that would be given in the interview, and also vice versa. Then the third area of information collected for the fidelity review was the health record review. And so we would have someone, a staff member, who doesn't provide clinical services to any clients on the team, but who is familiar with the site's electronic medical record to complete the health record review. And it would be providing us with information on about 13 of the 31 items on the scale. And so I should say, so these 3 sources of information would corroborate each other. For example, an example is family psychoeducation. We are expecting that the families should be receiving about 8 sessions of family psychoeducation, at least during the first year of a client being enrolled in the program. So on this, the health record review, the health record reviewer would tell us for each client how many sessions of family psychoeducation they received. In the program documentation, we would be able to see the family psychoeducation materials. And then in the interviews, we would ask them what method of or what form of family psychoeducation would you provide. And the reason this was important was, for example, the health record reviewer may complete the list, which would be correct, but then when we go and do the interview, we find that the clinician or the people who are responsible for providing family psychoeducation never had any training, or that they maybe don't provide any family psychoeducation. And so with that information, we would then know, well, actually the site, even though the health record reviewer has indicated that a client received so many sessions, the site isn't actually providing family psychoeducation. And I want to briefly show you a sample of an item. This is our supported employment item. As you can see, it's rated on a 5-point scale. Some of the items, we made a lot of improvements to these because the initial scale items, the anchors, were more qualitative in description. We found that it's a lot easier if you actually just have a list of expectations that you have for a given practice. So in supported employment, we had a list of 8 expectations, and then we made the anchors as to how many items, expectations I should say, did the supported employment or supported education specialist meet in order for us to do our rating, which made it much simpler. So then we, for 5 of the sites, we had 4 raters in order to test inter-rater reliability. And in general, the reliability ranged from moderate to excellent. And the sites actually had a very good spread in delivery of services, which the Fidelity Scale captured, as you can see in the range of the total scores. So the Remote Fidelity Assessment revealed several benefits. One, the first being that it was cost effective. There was no travel, no flying time there. Also, there is fewer staff hours lost. So a Fidelity reviewer isn't losing a day to travel to conduct the Fidelity review. Also, at the site, oftentimes when you're doing a site visit, you need to have a staff member sort of babysit you a bit and make sure that everything is all right with the Fidelity reviewers. That's not necessary if you're not at the site. It was also accommodating to staff work schedules. I had interviewed someone while they were in the car. I had interviewed people at the end of the day of their work, after they were finished work, whatever was most convenient for them. I actually conducted a training while I was in the car driving, which wasn't very good. But it only happened. Yeah, that was not by choice, but that only happened once. And also that it was, another benefit is that it's efficient. When we have to do client chart reviews, when we go to sites, we're navigating through paper records and electronic medical records that we're not familiar with. If we have a staff member do it, it just reduces the amount of time because they know where to find everything. And also, another benefit to doing it remotely is that we had information in advance of the interview. So I was able to prepare for the interviews and kind of have more focused questions because I already had quite a lot of detail in advance. But I should say this last point also can be seen as a limitation because there were instances that we didn't get the information in time for the interviews, and sometimes we didn't get the information for a couple of weeks, which delayed the rating of and completing the Fidelity review, which you wouldn't have if you went to a site visit. But then there are limitations, and the largest limitation we saw for a remote Fidelity review is our inability to make any observations. We couldn't make any behavior observation as to how well a site is actually providing the quality that which they're providing the services. We didn't have any client or family perspective, so it was very difficult to assess the level of shared decision making that was happening at the site. It was difficult to assess their perspectives, whether or not their goals are being incorporated, and they feel their goals and needs are being incorporated into their treatment plan. And also for the client charts, we don't have a first-hand review of the charts. Yes, we have someone at the site doing the review, but we don't know if maybe the team leader reviewed it before they sent it to us. So that bias could still be there. There was also some scale limitations, which we are working through, in that some of the items do require some subjective ratings, and some of the ratings required us to be proficient in the different manuals. And for me, I just started, so I wasn't proficient in the On-Track, Navigate, ESA manual, and the different terms they use for different therapies. Is IRT considered cognitive behavioral therapy? Does that work for this item? So it required this extra knowledge that I just did not have. So those are some things that we need to work on with the scale. And also, we don't have evidence for predictive validity. But this moves to our future directions, in that in year 2, we're going to be modifying the scale. And also in year 2, as Preeti mentioned, is that when we're going to be collecting the outcome data. And that's when we'll be able to develop evidence for predictive validity. And I should say, so these were the limitations that we observed, but I would be very interested later when we have, it's open for discussion, for you if you observe any other limitations or things that we should be more aware of when doing a remote fidelity review. And I'd like to acknowledge our Fidelity team. We have Gary Bond and Matt Landers, and also Don Addington, who's based in Calgary. He was the developer of the first episode, Psychosis, Fidelity Scale, and was all these members were key in making this successful. So thank you.
All right, thank you. Tara, we have time for you to give your comments, and then we'll be able to open up to the audience for discussion and questions.
Okay, well, thanks everyone for hanging out, and thank you for allowing me to pretend to be Lisa Dixon for the day. It's amazing. It's invigorating to be her. As was mentioned during the various presentations, you know, my view here comes partly as a researcher, but also as a stakeholder in this process. So my perspective is informed by both of those things. And I was interviewed, I think, as 2 roles, because I'm the executive director, which means I'm an administrator, but I'm also the team lead. So I'm a supervisor and trainer as well for our team. So I want to put that out there. As a stakeholder in this process, I want to highlight my appreciation for the approach that WestStat took. Their mixed models approach, I thought it was really nice to not just feel like I was giving you numbers, but that you were going to talk to me about not just the fidelity, but the experience and why we do what we do. And I think today it was really nice to see those relationships illustrated. So I think there was a lot of value in the way they set the study up. And so they did it with this idea of trying to capture the richness, but also to make it doable for sites to participate. The outcomes that Avram showed, they're not terribly complicated, and it was easy for us to do, which I think for all of us who are trying to serve as many people as we can in our community, and yet also wanting to contribute to a large study, it made it more feasible for us. I really appreciated the telephone engagement pieces that were done. I think that all of the reasons you pointed out in terms of the flexibility for staff to be able to engage when people were available. Like if you want to talk to my psychiatrist, I can tell you that's at a very specific time. So it allowed us to make more people available to provide information. I also really appreciated the way the chart review was done. I understand from a researcher perspective how you were like, we'd like to look at the charts ourselves, and really try to confirm if this is what we're trying to measure. But for us, with IRBs and all of those things, it was so much easier to keep the PHI within our system and to just provide that data for you. So I thought they had this really great balance of trying to get as much data as they possibly could while also respecting the clinical process that was happening at the sites. So in terms of the data that I saw, and this is my first time seeing this data too, I was really struck on the survey data, the graph of the increased number of sites that really corresponded to the increase in the money. And it made me think about this morning's presentation about how money really drives the delivery of care. And I know in California, we already had money for this work. And so there were already a lot of sites doing it, but then there were more sites doing it because of the block grant dollars and that the explosion across the country as a result of that. I thought that was interesting. So there's this money that's driving care, but then the survey data also showed that there were 3 FTEs in general, usually serving 10 to 40 patients across these giant catchment areas. So to me, it really spoke to what I see in Sacramento County as well as in the adjacent counties that we collaborate with. This, how do we do as much as we can for as many people as we can with as little money as we can? The mental health block grant dollars are actually very small. And I know for some California counties, the rural and very, very small counties, the portion that they get from our state, it's really hard to do anything with that. And so what we've seen programs do is divide it up in teeny tiny chunks across multiple staff members. And I think that this is another way in which money, to me, is diluting care, because it is hard to create that team-based, flexible approach and to make sure that people are delivering the services with fidelity if they only have 0.1 of their FTE devoted to the service. So that was sort of an interesting piece. I also, the small patients with these large catchment areas really highlights to me that we're probably not serving as many people as need service. I know that's the case in Sacramento County. And so the mental health block grant dollars are great, and I think they're not sufficient to really serve all of the folks who need these services. In the survey data, I was also struck by how there were fewer programs who were integrating physical health or cognitive remediation. Those are at the low end. And those are evidence-based practices in early psychosis care. We saw some really great data on physical health and serious mental illness today. And they aren't coming into these programs. And I really think that speaks to the divide between research and practice that we have been talking about today. We saw the same thing we did a survey of California counties and asked them, what are you doing? And we saw the same thing. This was published in Early Intervention Psychiatry with Mark Saville as the first author. And those services fell to the bottom in California. So it's consistent with what we were seeing. Okay, in terms of, I sort of combined the survey and process data in terms of talking about the catchment areas. So one thought that I was wondering about, Preeti, with your data, the staff being split over the roles and all of the accommodations they were making. When I talk to providers in this space, there's a hypothesis that that's contributing to increased turnover. And so I was wondering if you have data about I don't remember giving turnover data, but I can't remember. And so I was just wondering if there's any association there that might be helpful to look at, because that's something we're talking about a lot. I've mentioned that I really appreciated the Fidelity approach. And I was not surprised to see that less than or about half of the programs do regular fidelity measure. I think that is challenging. I think it requires a whole nother level of data collection that's hard to do when you're trying to drive your money towards care. And so I agree with you. I think the FEPS is a very nice model to really capture components of care that isn't model driven. But then I noticed in your, the one item you put up, which was the supported employment, that it had IRT. Sorry? It had IRT. Is that one of the, or IPT, individual placement and training? IPS.
One of the eyes.
It was hard to see from my corner. It started with an I. IPS, yes. Individual placement and support. Yes. And so that is a particular model, right? And so I looked, and it was like that entire model or item was rated on IPS. And I was like, well, we didn't get that model because we didn't get that item because that's not the model we use. And so while you pick something that was not model driven, you then put models in and assumed that that was the right way to go. So just wanted to point that out. Because of our experience doing this evaluation and the way we did, we're using the remote assessment fidelity model in the California evaluation that we're developing right now. And so we're working with Don Addington to be able to translate that into an evaluation of more California programs. I guess in summary, I was sort of thinking about how do we take this information and translate it into practice now? How do we, for example, in Preethi's presentation, how do we take this knowledge that you've captured about the ways in which programs have successfully modified CSC and disseminate that to more places? And I've had the privilege of being part of some of the NASHBID and SAMHSA webinars, and I'm like, oh, is this something we should be telling people? If you live in a rural area, here's one way in which you could serve more people or modify things. I think that's something that many programs are hungry for. I'm also interested to see your future analyses related to whether the presence of specific components is related to specific outcomes. I think that'll be a very interesting analysis. I'm also curious as to how this project will impact the disparity that we still see in the provision of CSC care for individuals with insurance. Because you pointed out in your slide that CMS is approved first episode care, and the majority of the programs that you surveyed are Medicaid programs. But I also have an insurance-based program, and I can't bill for the majority of the services. So we aren't seeing it translate into private insurance paying systems, and that is creating a disparity in services for people. So I'm wondering if this data is going to help to drive that conversation forward. And then finally, the EpiNet RFA was posted this week, and we were sort of talking about, like, how is this going to drive the proposals that may come in for EpiNet? And I think one piece that I would like to suggest is, I think you guys have developed a fidelity assessment approach that is really great, and I know I would use that. And I really hope that respondents to that RFA also really think about how to best include the clinics and get data from the clinics in a way that was as unobtrusive as possible, which I think you guys also have demonstrated. So those were just 2 points that I thought I would make. So that's it. Thank you.
Terrific, thank you. I will say one quick thing and open it up. One of the things out of the process interviews, obviously, is we spent a day, usually, in each of the places, and we were very fortunate. I did some, Preethi did some. We had Howard Goldman and Dave Shern and Lisa Dixon doing these interviews. When we sit down and talk about the interviews and what we learned, it has many of the things that you touch upon came up in those interviews, and how we're going to code and capture that's going to be really very interesting. So you saw sort of the tip of the iceberg that won't sink any ships, but that has a lot of information to it. And you raised some really important points that we want to try to pull out of there, and also link to our fidelity process. So I don't need to say more. I just wanted to mention that briefly. We are happy to entertain questions or have any discussion from anyone who would like to do so.
Thank you for the great presentations, and thanks for sharing the early data with us. Very informative, and also appreciate the great discussion. My name is Yuhua Bao. I'm from Weill Cornell Medical College, and I started working with Lisa Dixon's group a few years ago. I came from a health economics background, and so very concerned about policies, and in particular payment. So we presented some early, a prototype of a payment design support tool yesterday to design a multi-part and especially a case rate-based payment for CSC. So you know where I came from. So my questions are related to the financing side of CSC. So the first question is, in your site interviews, did you ask about their revenue sources other than the mental health block grant? What is the general sense of where they kind of get coverage or financial support to run the team? The other question is regarding the staffing side. So you talked about a lot of the accommodation or, splitting roles among different clinicians, the different, FTEs. But I wonder if there's also large variation in terms of what credentials, what types of professionals are serving a particular role. For example, for the team leader, that role can be played by a licensed clinical social worker or some non-clinical social worker, right? Etc. So I wonder if you have any insights gleaned from your visits to share. Thank you.
Those are great questions, and I'm going to start and answer and let anyone else chime in. Tara, I know you run one of these programs, or a couple of them, so you have a few comments. On the financing side, we did ask about where the dollars came from. We saw some initial indications in the site survey, the usual suspects, Medicaid, private insurance. And then in the process, we asked more detail. So for example, in California, there's a whole funding process that's not replicable elsewhere through the Mental Health Services Act in that state. That's very important to the programs that we interviewed in California, but there's no such thing in other states. And so you can't ask always canned questions because you never know what you're going to find when you go out there, which is why we did the process and everything. We did ask, and I don't want to speak out of turn because we haven't really consolidated our results there yet, but I think it's safe to say, and chime in if I've got this right, that we saw a wide range of different ways that these services are funded. They tended to rely, if they didn't have special things like California did, on Medicaid. Private insurance created a lot of challenges usually for the sites, depending on how they were set up, although we encountered some sites that had no Medicaid access. Virtually none, and we're relying on their private insurance or their hospital payment systems in various ways to fund it. So one of the problems with this, and Howard and I just finished a paper about this, is the funding mechanisms for all of this are very complicated because you're moving from the child system right to the adult system. The requirements on the child system are different than the adult system. People transition and magically turn into adults according to the funding mechanism, but they don't for the programs. And then they have different qualifications in Medicaid on different sides, depending on whether you're a kid and it's early periodic screening detection treatment, or you're an adult and it has to be SMI based. And so there's a real hodgepodge, which is, I'm sure, what you have seen in how these places are funded. And they've generally done what they can, if they don't have something like the Mental Health Services Act, to braid these things together in these sort of I'll just say, editorializing a bit, kind of fragile feeling ways, because there isn't a set way of paying for this that transcends the age groups and goes forward. So that's item one, and I'll let you guys chime in on that if you like.
Yes, so I can speak to the second. So just to clarify, you were asking about diversity of staff roles and training and whether or not we saw differences across the sites. Is that correct?
I guess there's a tension between you want sites to be to accommodate their local, situations, right? And it is, teams are doing that, in fact. But on the other hand, you don't want them to deviate too much from evidence-based approach, including, how you staff a team. So I wonder if, if you see. If there were like prototypical team makeup that you saw from your visits, I guess.
Okay, well, I can say that, well, starting with the team leader, most were, I'd say, master's level, a couple PhD level counselors. I think, Yes, so most had like a master's in counseling. For Fidelity, to get the highest level of Fidelity, we expected the team leaders not only to provide supervision, but to also provide direct services to clients. So to be quite completely connected with the clients that they are serving. There were some instances where we had the prescriber who acted as the team leader, or like at some sites you would have psychiatrists, other sites had nurse practitioners. For the clinicians, there was some variability there as to you'd have mostly the social workers, I would say, like master's level social workers acted as clinicians. I think what really would, and in addition, some teams also had nurses. Not all the teams did, but that would speak to the principle of primary care services in the coordinated specialty care model. The nurse would be able to address those. And then there were also peers on the team and family support workers. But the thing that really would differentiate and keep the quality of the services high would be the level of supervision. Who are you receiving supervision from? What sort of training did you receive? Are you receiving, like Abram was talking about, a lot of sites continue to receive ongoing consultations from the On Track or Navigate or ESA. I would say that was where we did see some distinctions, that some sites were having that high level of supervision from external sources and also internal supervision, whereas other sites less so.
Yeah, I would say the only thing I would think about from a health economics perspective, because we did a pilot analysis in Sacramento County, looking at cost, utilization, and outcomes associated with the care that we provide in Sacramento County compared to outpatient clinics. And one of the things we had a very hard time capturing the cost of was the training and the ongoing training. That's not something that you capture in a billing code. And so it makes it really hard, and sometimes it's reflected in a budget, and then sometimes it's not. And so one of the things that we see oftentimes in our contracts with other counties is a challenge, like a struggle for them to keep their staff while also needing to support this ongoing training and supervision. And so I think that's, in terms of understanding the economics of these programs, that's one cost that we really need to think about how to quantify, because it's sort of hidden in the program, but it's what makes or breaks the program.
Yeah, just real quick, we did see challenges for sure in the training side. There are only so many people from On Track and these places, and they would come out and do the trainings, and then if staff turned over, which happens, they had to retrain. And that was a challenge for a lot of sites for just the reasons you spoke of. They had to allocate resources, and then they couldn't figure out how to pay for it again. We did see some of that. Susan.
Thanks for a fabulous panel and some really thoughtful observations we were discussing, Tara. So my question is regarding the Fidelity Assessment, so maybe more for Valerie, and what you'll do with the findings in terms of providing feedback to the sites. Like, will they get their Fidelity ratings, and would they be presented to them in the context of here's how you did and here's the aggregate, or how will you do that so that it's informative in a quality improvement way?
Oh boy,
Maybe that's for later stage.
That's such. I'll start. That's such a great question, and we're kind of laughing up here because we just had an extended discussion with Gary Bond and Valerie and the team about what we could give back to the sites and what we could afford to give back to the sites, which are sort of different things, and how we could do that. We sort of decided, and tell me if I got this right, so we would do this at time 2.
Yes.
Because we felt like, go ahead, Valerie.
Yes, in terms of detailed feedback for each specific to each site, we thought that we would do that. We will do that in year 2. In year 1, what we're going to do now, I think we're going to put together just an overall summary of the range of services that we saw and provide that to the site. So then it will be on for them to reflect, looking and seeing where they would fall into however we describe what we observed. Another reason we aren't quite at the stage to give individual site feedback because of we're still developing the FEPS scale, so there are no benchmarks. We couldn't tell the site, you met fidelity or you did not. So it wouldn't be quite appropriate to provide a fidelity score at this time.
Yeah. In short, we're proceeding with an abundance of caution while remaining enthusiastic.
Thanks very much for the presentation. I have just some more detailed questions about how the fidelity assessment was carried out. How many records did sites review? What was the time burden for sites in doing that?
Yeah, no, that's great. So I can talk about, so just time burden overall. Just with the interviews, team leader interviews were about an hour to an hour and a half. The prescribers and supported employment specialists were about 30 minutes each, and the therapist interviews were about 45 minutes to an hour. So that adds up to what, three and a half hours for interviews. Then we surveyed for the health record review. They needed to review 10 charts, and that ranged on average about 3 hours to do. And then collection of the program documents, so these needed to be submitted electronically, that really ranged. So I had one site tell me that they did it in 15 minutes, and probably the reason that is that they already had everything on their computer in electronic form. Whereas on the other hand, one site, it said it took them 2 hours to compile. So in general, I thought that the time burden was pretty reasonable. Mm-hmm. Oh, and then the training. So the team leader, I met with the team leader for half an hour, and then the health record reviewer for half an hour. Mm-hmm. And then there was time on the team leader side working with our research assistant to schedule everyone. So scheduling, I'm sure, takes a lot of effort. I'm very fortunate for Matt, who's up there. He organized all of that. Mm-hmm. Yes.
And just one add-on real quick. One of the things that really drove some of our process around the fidelity interviews at the beginning, at least, was the Irb concerns. It's very difficult, for us to have people seeing charts. And we talked about, sort of de-identifying them. At the minute you don't de-identify something you should have, we've got all kinds of issues. And so we just decided we were better off not seeing anything. Which did shift some of the burden to the sites, but probably, I think, Terry, your site, in the long run didn't, because we didn't get into these IRB problems that would have just probably waylaid us. And so that was part of how we ended up with this sort of remote control version of doing this and us not seeing the charts. It just, on a study with 36 sites, you can imagine it's like anything that can go wrong will and would have, and then we would have had to have reported that and dealt with all the consequences and stuff.
My name is Victoria Doyon. Thank you so much. This has been a very, very rich, very contextual session. Happy to hear it in such a formative stage. And since, if I heard correctly, we're hearing it for the first time, and the question was, what could you give back? And I would say that this discussion itself may not be, though it's being recorded and will be available for digestion, that maybe that might not be a bad tool for outreach. An 88% response rate in the science that we all are about, deep bow, and it suggests a really vested audience.
It does.
And coming up through the public health system from county to state to regional, national level, it's also, Tara, really helpful to hear about that diffusion of the funding stream. I cut my teeth in public health in Minnesota, and I know what, the northern reaches, inter-county collaboration looks like to try to spread the wealth. And so this is maybe just a comment, but a thought for the push-pull in the data sharing. And when you have this qualitative investment, Valerie, that you've spoken so clearly to, oftentimes that audience will have, things will resonate downstream as a consequence of what's been asked of you. So I think you've asked a really, really provocative question. What can we give back, even in these early stages? And if it's not too idealistic, you know, this breakout session, the kinds of questions that have been shared, the feedback from Tara, even if it's for that 88% responders, you know, here's some food for thought, and just to invite the comments. The technology presumably is there, whether there's remaining funds in the grant to take a look at what might come back qualitatively from your stakeholder, engaged participants at this early stage for time 2, if that makes sense. Because I think that there's real opportunity in where those dollars are spread out, the 0.01 FTE, A, and then B is, it's been rolled out through this extraordinary investment from the federal agencies at a national snapshot, but maybe there's some synergies that are regional that could pop up for exactly, that would kind of get at that the economics of it, right? Thank you so much.
Thank you for the comment. Thank you, very helpful. We're just about out of time, but we've got 5 minutes. If anyone else would like a last final question for the afternoon. Okay, if not, thank you so much for joining us this afternoon. Really appreciate it, and have a great rest of your day. And we'll hang around if you have any further questions. Thank you.
Thank you.